Okay, thank you for joining us for this week's PGY2 Pain and Palliative Care webinar series. Poor guy, Dr. Brad Rea will be our presenter one more time, but we do have some folks signed up for future lectures, so hopefully he'll get a little bit of respite care, as we like to say in the hospital. Today his talk will be on end-of-life management of COPD. So with that, I'll give it to you, Dr. Rea.
Thank you, Dr. Herndon. So as you said, I will be doing or performing my presentation on end-of-life COPD. And first, I will kind of go over COPD rather quickly and then talk about how we kind of manage end-of-life care. So COPD, essentially what it is, according to the GOLD guidelines definition, is a common, preventable, treatable disease characterized by persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and lung to noxious particles or gases. So it's different than asthma in that it's not fully reversible. Asthma is one of those that I'll talk about a little bit later, but it's one of those that kind of waxes and wanes depending on the factors that lead to it. COPD is more constructive, more compound, and it's due to scarring and continued damage that occurs with COPD. One of the things that's interesting about COPD is it has variable timelines for patients. So it's not one of those that you can definitively say that, okay, they're at this stage, they're definitely going to pass, which kind of brings in a problem with hospice and palliative care, because a lot of times physicians have a hard time prognostically determining when they are nearing the end with COPD. Right now, it is classified as the third leading cause of death, and it is one of the only disease states that is increasing. By 2030, it is expected to increase pretty dramatically, and that is due not only to the risk factors associated with it, but our treatments. There really is no there is no cure for this disease. So kind of talking about how it develops, it's essentially two different diseases in one, or it's often two different diseases in one. It's chronic bronchitis, and emphysema. So chronic bronchitis is usually associated with chronic or recurrent excessive mucus secretion. So that's why a lot of times the symptoms with COPD is going to be mucus excretion or secretion as well as cough. So it's going to be recurrent mucus secretion in the bronchial tree. And then you're also going to have that chronic cough. It can be every day. It usually worsens and is often one of the more some symptoms of it, although not always the most problemsome. As far as emphysema goes, it's usually defined as abnormal, persistent enlargement in airway spaces, distal to terminal bronchioles, accompanied with destruction of their walls. And one thing important to note is that there is no fibrosis with this part of the emphysema, although in COPD, a lot of times we do have fibrotic development or scarring, rather, that develops in their bronchioles and airways. So the etiology of COPD, the number one risk factor for it, and is the cause for between 90 and 95% of COPD cases, is cigarette smoking. And that isn't only to patients that smoke, but it's also to patients of family members who smoke. So first and secondhand smoke. I don't think there's been a whole lot of data with third-hand smoke or smoke that's like on the clothing that people smell, but definitely first-hand and secondhand smoke. They are 12 to 13 times more likely to die from COPD, and roughly 15 to 20% of smokers will go on to develop COPD. Some other problems that can lead to the development of COPD is dust and chemicals. Now, in the developed world, cigarette smoking is the most common cause for COPD. However, in the non-industrialized world, a lot of times it's going to be not as heavily influenced by cigarette smoking as much as it is to air quality and air pollution and different chemicals depending on their work environment. So if they're around asbestos, if they're around gold mines or some kind of mining situation where there's a lot of particles in the air, they are going to have an increased risk for developing COPD. Now we have air pollution, and the other one, which only accounts for about 10% of the cases of COPD, is genetic predisposition or AAT deficiency, which is essentially alpha-1 antitrypsin deficiency. And it's a genetic deficiency in the production of the enzyme AAT or alpha-1 antitrypsin. The purpose of alpha-1 antitrypsin is to protect the lungs and alveoli from destruction by elastase released by neutrophils, which I'll talk about in the next slide a little bit about how this happens. Typically, these patients develop COPD at an earlier age, about 20 to 50, as opposed to the normal patients with COPD that develop it a little bit later in life. So with the smoking, essentially what happens is you get lung inflammation, and then two things can happen. You have oxidative stress, which is more due to the smoking and free radical particles that are associated with that. And then you have the proteinases, which is more associated with the AAT or alpha-1 antitrypsin. And both of those can lead to the pathophysiology of COPD. So really, I'm going to talk quickly about some differences between COPD and asthma. Sometimes they are co-occurring, sometimes they're not. But really with COPD, the main cells associated with it are neutrophils. On the flip side of asthma, it's typically eosinophils, and that's because it's typically an allergic reaction or allergic response to some chemical in the environment or some particle in the environment. You're going to have large macrophages in COPD and increase in CD8 lymphocytes. While on the flip side with asthma, it's usually a small increase in macrophages, and you have CD4 increase in lymphocytes. Also with asthma, you will have activation of mast cells, and that is due to the allergic reaction of it. So COPD, it's typically midlife to late life, depending on the actual etiology and the risk factors for developing COPD. But asthma is one of those that's usually in early life. And a lot of times you don't really get rid of asthma, but it becomes less problemsome as you age. So you can have COPD and asthma, but it's not typically the case. And then kind of how the progression goes, COPD is typically very slow progressing, while asthma can happen at any time, and it doesn't necessarily progress like COPD progresses. Another distinguishing factor of COPD and asthma is asthmatics are usually the worst at night or early in the morning. So they'll a lot of times wake up at the middle of the night, not being able to breathe, start wheezing, and having problems with nighttime awakenings. So what actually happens when patients develop COPD, or how do they develop it, or what happens? So essentially, inflammatory exudates often present and leads to an increase in goblet smells and mucus glands. Mucus secretion is increased while ciliary motility is decreased or impaired. So you essentially have these cells that are increasing excessive secretions, but also the ciliary motility, or the things that kind of help move those cells, get impaired too. So it's kind of a double-edged sword where you're not only having more secretion, the ability to get rid of that secretion is also decreased. You're also going to have thickening of smooth muscle and connective tissue, and you're going to have scarring and fibrosis. Now, the scarring and fibrosis is typically induced by repeated injury and repair due to chronic inflammation. So you're going to have injury and repair, and what that's going to do is cause scarring and fibrosis to start to develop. When you have scarring and fibrosis, you kind of diminish the ability of the alveoli and other respiratory functions to work properly due to that scarring and fibrosis. You're also going to have a reduction in elastic coil of the lungs and a loss in alveolar surface area. So you're not going to be able to have the same recoil in the lungs. And a lot of times that's why you will see patients start to use accessory muscles when they try to breathe, where you'll see them kind of use their entire bodies to breathe as opposed to just their muscles. You're also going to have a gas exchange alteration, where the gas exchange are not going to be as efficient, which is why a lot of times you're going to see patients being hypoxic when they have COPD. As far as the clinical presentation, it's usually thought of a triad or three gold symptoms or clinical symptoms that are typical, and that's cough, dyspnea, and sputum production. As far as the diagnosis, we typically diagnose with spirometry, and that's using an FEV1 to FVC ratio, and we're looking for less than 70% to diagnose COPD. So what actually happens, or what do you look for, or what do you see when patients have COPD? So one of the things that often happens is cyanotic mucosal membranes. Now that can be different areas, but essentially what that is blue, can be white, can be purple, can be in the lips, can be in the hands, can be places, but you're going to have cyanosis due to that impaired oxygen exchange and the hypoxia that patients often experience. Now this can happen acutely or chronically. They can go into exacerbations and have this worse often, or they can have a little bit of a cyanotic level throughout, but when you give the patients oxygen, it usually gets better. Another thing that happens, or is often a symptom or presenting symptom of COPD, is having barrel chest. And no, it's not like the guy present before you. It's more where your chest becomes more barrel shaped. And not that this picture that you see as a guy that's a bodybuilder or anything. No, it's because you're using those accessory muscles and your chest is actually building up due to that use. You're also going to have an increased respiratory rate, and that's going to try to compensate for that impaired oxygenation. You're going to have shallow breathing, pursed lips during expiration, and accessory muscle use. So how do we figure out how severe patients' COPD is? We're going to have or use the gold standard to figure out the severity of airway limitation, and that's levels gold 1, 2, 3, and 4. And these are based on FEV1's post-bronchodilator administration. So these levels are post essentially administration of bronchodilators, and you can see the different levels. So it becomes very severe at gold 4, which is going to be more typical of when patients would be on hospice or palliative care. We could see them in gold 3 or 2, but typically gold 4 patients are what we're going to see in the palliative care setting. Another way to look at COPD is their risk of having an exacerbation. So this is from the GOLD guidelines as well. And essentially what it is it looks at different levels and different areas basing on the exacerbations per year, the risk of symptoms, which that's what the MMRC and the CATR, and then spirometric grade, and is based on a chart, and it kind of just looks at what risk are they of having an exacerbation. So the CAT or COPD assessment test is preferred by the GOLD, and it ranges from scores of 0 to 40, typically scores of 10 indicates a high level of symptoms, and the Modified British Medical Research Council, the MMRC questionnaire, assesses disability due to breathlessness. So typically a grade greater than 2 is a high level of symptoms. So you can see that's why here on this slide that they have the levels of 2 and 10, typically greater than those have high levels of symptoms. So a patient that is D is going to have a lot of symptoms and be at a very high risk for exacerbation, where a patient of B might not have very many might not have a very high risk of having exacerbation, but they're still going to have a lot of symptoms. So what happens in these patients, what happens in hospice patients, or what happens in COPD patients, their last 2 years of life? So a couple of things happen. First off, hospital admissions for severe exacerbations increases pretty dramatically in these final 2 years before the COPD causes a fatality. Another thing is patients often become housebound, and that's due to not being able to breathe, not being able to move around like they used to, because they get very short of breath very easily. FEV1s are usually 30% or less at this point, which is essentially how much air they can breathe in 1 second. Oxygen therapy is typically needed at this point in long term, and that's going to depend on patient specifics and their own requirements for how much oxygen they will typically need. Another thing that typically happens is patients become depressed or anxious, and that's due to the fact that a lot of these patients, because they develop COPD, they can't do the things that they were once able to do. They can't walk down the street to get their mail anymore. They can't cut their own grass. They can't do a lot of these things that they were once able to do, and they lose a lot of that self-worth of being able to do things, which can be very detrimental to their mental health. So many COPD patients that I'll give some statistics later, actually go on to develop depression and anxiety, and it really leads to a poor quality of life for these patients. You're also going to have weight loss and other comorbidities, such as congestive heart failure, that can happen during these final 2 years of life in patients with COPD. So now I'm going to steal an idea from one of my old co-residents that they did in their last presentation, if you guys want to sign in. But what do you guys see as, well, here, you guys can read the question. And then if you want, you can either go to the website or text in. This is an open response. So you can pretty much type whatever you want and it'll show up. But what is your guys' opinion on what's going to slow or stop the progression most in COPD patients? Okay, yep, supplemental oxygen. Oxygen is going to be very important. I don't know if supplemental oxygen has really been, that's what I was trying to go for. Yes, quit the Marlboros. Smoking cessation is really the only therapy that has been shown to slow the progression and stop the progression of COPD. Now, obviously, if you're in an environment where you're exposed to a bunch of dust and particles, that could have an effect as well, but really smoking cessation has the best data to slow the progression of COPD. thank you for anyone that answered. So how are we going to slow the progression? Well, we can do smoking cessation. So there's quite a few different routes. We have nicotine replacement therapy, which comes in all different kinds of formulations. It comes in patches, gums, lozenges, patches. It comes in many different formulations, but there's also other options such as Chantix, which has its own problems with possibly increasing nightmares and things like that, but it does have data to support that it does help with smoking cessation. And then we have bupropion, which is an antidepressant, which could be beneficial as well. Now, typically, if the patients are at severe COPD or quitting smoking, it doesn't necessarily reverse what's already happened. It might slow, it might reduce exacerbations, but it's not going to reverse what has already occurred. So we do have bupropion. Obviously, we want to know if they've had a seizure disorder, and we want to make sure they give it to them in the morning since it can be somewhat excitatory. But there's also looking at, which I'm not going to get into very much at all, but looking at like e-cigarettes and things, and there's still data coming out about that. And it's kind of mixed whether it actually does help people quit smoking. There are some studies that do show that it does help people quit smoking, but that's still kind of up in the air whether that's recommended or not. So what are we going to use for these patients that have COPD? Well, we have bronchodilators, we have inhaled corticosteroids, we have combination products, we have oral corticosteroids, we have phosphodiesterase 4 inhibitors, we have methylxanthines. And then another thing that we have some other therapies I'll talk about a little bit later, but these are the typical therapies that we would use in patients with COPD. So bronchodilators are essentially medications that increase the FEV1 or change other spirometric variables, usually altering airway smooth muscle tone. So what they're going to do is cause vasodilation, essentially. And here's some quotes from the GOLD guidelines. Now, one thing to take in a note, I'm going to talk about these more in the aspect of hospice, but the GOLD guidelines don't really talk about hospice or palliative care. There are different studies and different research papers out there looking at hospice care, but GOLD guidelines do not really go into much depth about that. But they do say they prefer long-acting agents over short-acting agents because they have shown to reduce exacerbations and reduce problems associated with COPD. With that being said, however, hospice patients, short-acting formulations are sometimes preferred, not only because of cost, but you really have to think about how they're going to be intaking these medications. If they're going to be using an inhaler of some type, a lot of these patients on hospice and palliative care are rather old. So their ability to actually get a deep breath, to get that inhaler and to get that drug product deep into their bronchioles can be problems. So a lot of times, at least from hospice or the hospice setting that I come from, we would use things like duo nebs, where you have a nebulized form where it's easier to get into the bronchioles and get deep into lungs as opposed to trying to have the lungs to actually pull it in. So a lot of times in elderly patients, it might be more beneficial to use something that is able to be nebulized. Another thing they mentioned is inhaled bronchodilators are preferred over oral bronchodilators, and that's due to side effect profile typically. And efficacy. The inhaled bronchodilators have been shown to be more efficacious than oral bronchodilators, and you don't run the risk of having systemic effects as much as you would with the oral bronchodilators. And then the last thing they really say is theophylline is not recommended, and that's because it has a relatively low efficacy and it has a high side effect profile. It has a lot of drug interactions and it has a lot of problems associated with it. It's typically, back 20, 30 years ago, it was used a lot more often. Now it's very rarely seen, but it is not recommended to be used unless it is like a very last line agent where you're having COPD refractory symptoms that are not treated by anything else. That would be something you could potentially look at, but I still really wouldn't recommend it or put it very high on my list. So bronchodilators, what do we have? So we have the beta-2 agonists, and it comes in several formulations. Now, I will say that these are not all-inclusive lists. There are products out there that I do not have listed on these slides. However, here's an overall list of the most common ones that you may see. So you have the short-acting beta-2 agonists, albuterol and levoalbuterol. Albuterol is typically preferred. It's cheaper. It's been around longer. It's generic. And then the levoalbuterol, people sometimes go to that because it has been shown in studies to reduce cardiac problems associated with albuterol intake. However, if you really dig deep into the studies, it is not much more beneficial than albuterol at all at risk of tachycardia or problems associated with it. As far as the long-acting, we have several. We have formoterol, salmeterol. There's supposed to be an R in there. I changed my slides this morning and it didn't save, obviously. So we have formoterol, salmeterol, and indicaterol. Indicaterol is the newest agent, which is actually once daily, which I'll talk about in the next slide. As far as the anticholinergics, we have ipratropium and tiotropium. So tiotropium is Spiriva. And then for methylxanthines, aminophylline and theophylline. So these are typically what we consider our bronchodilators. So as far as the beta-2 agonists go, how did they work? They relax the airway smooth muscle by increasing cyclic AMP. And they have different duration of actions. And one thing to realize is that these are a little bit different than the anticholinergics in that these act quicker than the anticholinergic, especially the short-acting. So the short-acting product, or the short-acting agents typically last 4 to 6 hours, while long-acting typically lasts about 12 hours, other than the newer product, indicaterol, which is once daily, and it lasts 24 hours. Now, one thing to keep in mind is that these agents are going to have side effects. So you do run that risk of tachycardia with these agents. You do run a risk of hypokalemia. However, that is not seen as typically that big of a problem, because how these agents cause hypokalemia is they push potassium into the cells, and then you have a higher concentration of potassium inside your cells. However, if you were to stop taking the agents or anything like that, the potassium would come back out. So it's not actually a decrease in overall potassium storages. It's just like a functional decrease where you're shifting the potassium inside the cell as opposed to being in the serum. And then you can also have CNS stimulation or tremor, which could be associated with the tachycardia as well. As far as the anticholinergics go, so tiotropium, ipratropium, we also have a new one, aclidinium, which I'll talk about a little bit. But these block acetylcholine binding of the muscarinic receptors. And you can see the short-acting formulation is typically longer with ipratropium, the 8 hours, than albuterol, which is 4 to 6. But there are long-acting formulations too, aclidinium or tiotropium. Typically in hospice, we wouldn't recommend the long-acting formulations just due to the fact that nebulizing duonebs is convenient for patients. And from a price standpoint, long-acting formulations are rather costly, while duonebs are not near as costly. One thing to realize, these can cause some dry mouth. So patients already having dry mouth, this could be a problem. It can cause some nausea, and it can also cause a metallic kind of taste in your mouth. Another thing to realize is that these agents take a little bit longer to activate, which I mentioned a little bit earlier. The short-acting agent of ipratropium typically takes about 15 minutes to become active. When you look at albuterol, it only takes about 5 minutes. So it takes about 3 times longer to become active, but still a relatively short time when you look at the overall scheme of things. So now we're talking about inhaled corticosteroids. So there's really only been data in moderate and high doses in clinical studies to show any benefit, but there are a lot of problems with it. So when you withdraw these medications, it can lead to exacerbations. And then the treatment with inhaled corticosteroids doesn't modify FEV1 decline in mortality. There's not a whole lot of benefit from inhaled corticosteroids from a efficacy standpoint. They may be indicated in some patients, but they also are typically somewhat expensive depending on which agent you use. And typically at hospice, from my experience, a lot of patients do okay on duonebs without the corticosteroid. So how do they work? They essentially decrease production of inflammatory mediators. Here are some examples, budesonide, fluticasone, and beclomethasone. But there are some problems with these, especially in the elderly patients. So when you take these agents, you're running a risk of oral candidiasis. And really to prevent that, what you have to do is you have to wash your mouth out and spit, and you're going to try to get rid of some of that corticosteroid that can stick around in your mouth. However, a lot of elderly patients that are in hospice could have problems doing this. So it could run the risk of causing oral candidiasis in some of these patients if you were to continue these medications. It can also cause hoarse voice and skin bruising. So now I'll talk about some of the combination products. I'm not going to list them all because it'd probably fill up about 5 slides, but some of the more common ones, we have LABAs and LAMAs together, or long-acting beta agonists with long-acting muscarinic agonists. We also have LABAs and corticosteroids, and then we have the albuterol and ipratropium. So this is going to be kind of a first-line agent in hospice, especially with some of our older patients. So that comes in duoneb, which is nebulized, or it comes in combivent, which is inhaler. But the duonebs is going to be a good agent for hospice patients typically. We also have oral corticosteroids, and the gold guidelines typically say the risks outweigh the benefits for stable COPD because there is a lot of adverse events. Now, typically we don't think oral corticosteroids are a long-term, however, they are very beneficial in exacerbations, and they can help COPD. So when using oral corticosteroids, it's going to be important to weigh the risks and the benefits. So what are some of the risks? Well, you can have steroid myopathies with these, or essentially breakdown of your muscles. It can lead to osteoporosis with long-term use, as well as thinning of the skin, cataracts, and adrenal suppression. So typically, like you can say, or you can see, they're used for short-term treatment of exacerbations. But depending on the severity of hospice patients, how long they're expected to live, and different factors like that, they could be indicated if their COPD is severe enough. We also have the PDE4 inhibitors, or roflumilast or Dalaresp. So how do these work? These reduce inflammation by inhibition of intracellular cyclic AMP. They have no direct bronchodilator activity, but they have been shown to minimally increase FEV1. So what are some adverse events? So it is they do have more adverse or more risks than inhaled therapies because it is not an inhaled therapy. So some of the risks, you're going to have nausea, which can be very problematic in hospice patients because a lot of them already have nausea, vomiting, or diarrhea and constipation or other GI problems. You can have reduced appetite, which is also or could be a big problem in hospice patients because a lot of them are already cachectic, they're already losing weight, they're already at a malnourished state. You can have abdominal pain, sleep disturbances, and pretty bad headaches. So typically I wouldn't recommend this in hospice patients, and if they come in on it, I would recommend trying to take it off. That's something that would take a conversation with the patient and or the patient's family to determine what would be the most appropriate. So we have a chat thing. The GI diarrhea is the biggest claim from pulmonary docs. Okay. Thank you, Julie. So continuing. So here's a list of essentially the gold guidelines and what they recommend for first line, second line, and alternative choices based on that gold classification system of group A, group B, group C, and group D. And this is more for an all-inclusive COPD talk, not necessarily that this would be appropriate for hospice patients. That's going to be more clinical decisions and how the patient's symptoms are, because when we get to hospice and palliative care of these patients, it's going to be about treating the symptoms more so than using these different algorithms to figure out how we're going to extend their life. So what are some other therapies that you can often see? So we have the methylxanthines, and these are typically last line agents. They require, which I talked about a little bit in a few slides ago, but they require serum monitoring because they have a very narrow therapeutic index. If they also smoke, it increases clearance of the medication. It can lead to restlessness. It can lead to insomnia, tachycardia, tremor. There's a lot of problems with these medications. We also have mucolytics, which can be beneficial in helping some of those if they have a lot of chest secretions and things trying to get up, like Mucinex. It can be beneficial in getting some of those different chest secretions up. We have the antitussives. We have narcotics, which that's going to be very beneficial, especially when thinking about the signs and symptoms of COPD. When you have a cough and you have dyspnea and you have these problems, narcotics or opioids, another name for, are really beneficial in treating dyspnea and treating cough. So it's going to be important to use these therapies. Now, granted, most hospice patients are going to have at least some PRN opioid medication on, but it's going to be important that they can be used not only for their pain relieving functions, but can also be used for that cough and that dyspnea. Vaccinations are important. Now, hospice, that kind of is different, but it is recommended to get pneumococcal vaccinations if you have COPD and you're over 65. Also, the influenza vaccination should be given every year in patients that have COPD. And then oxygen therapy is really important. Palliative oxygen is often used, although treatment of breathlessness in end-stage COPD has lacking data to support oxygen therapy in as much that it will help. Now, if they are hypoxic, oxygen therapy is very beneficial, and I would never recommend not using oxygen therapy because it can be beneficial. It just, there hasn't been a whole lot of data to support oxygen therapy in treatment of breathlessness at end-stage COPD. So COPD at, oh, hold on, no, okay. So you guys probably just seen that, but here's another question. What symptom would you think being the most common and detrimental to the quality of life of patients with COPD? Oh, we have a split so far. So you guys might have gotten a little hint by looking at the slide previously, but typically the most detrimental and common symptom that patients experience as far as quality of life is the dyspnea. It's also typically the first symptom that patients experience when they develop COPD. Now, the problem with that and the problem with diagnosing COPD is that the dyspnea doesn't really become problematic or warrant like going to the hospital until about 40% of lung function has already been reduced. So a lot of times by the time they're diagnosed with COPD, they are at a somewhat of a advanced stage. Not that they're at like stage D or anything like that, but 40% loss of lung function is a significant amount. And you're right, the most common symptom at end of life COPD is dyspnea. So how do we treat that? We often use opioids for that, which do have very good data. And the problem is this dyspnea can be very debilitating. So opioids are very good at treating this dyspnea and the feelings of dyspnea. As far as benzodiazepines, they are often used for dyspnea. However, they haven't been shown to have a huge impact. Now that depends on their reasoning for having dyspnea. If it's just due to their COPD, yeah, they're not going to have a huge effect. But if they are having other problems going on, other anxieties going on, yes, it can help to reduce their anxiety level to kind of help control some of their breathing if they are having other reasons for having dyspnea. So what are some therapies that we can use for dyspnea? One thing is to sit upright, to use cool air fans. Fans and air movement have been shown to decrease the sensation of dyspnea in some studies. So not necessarily that it actually decreases the dyspnea, but when you think about it, if you're decreasing the sensation of it, you could really have a compounding effect to help decrease overall dyspnea. And then you can also do breathing and relaxation techniques, which have been found to improve dyspnea. And then there has been a recent double-blind randomized controlled trial which investigated the use of palliative oxygen in 235 patients with life-limiting illness and refractory dyspnea without hypoxia. So about 64 of these patients had COPD with the primary diagnosis of dyspnea. What they found was that the palliative oxygen did not significantly improve dyspnea when compared with room air. So really, if they are short of breath, you can give palliative oxygen to help, but it hasn't really been shown to improve that dyspnea. It might make patients feel better that they're getting oxygen, whether through nasal cannula or whatever route you may give it in the COPD patient, but it hasn't been shown to do a whole lot as far as helping the dyspnea. So another problem or another symptom that we often see in COPD is the cough. So really, before we start looking at the cough and what we're going to use with the cough, it's going to be important to kind of assess what the reason for the cough is. Now, COPD patients are an increased risk for infections, especially pulmonary infections or pneumonias. So if they do think they are having an antibiotic, if they're having green sputum come up, if they're having a fever, if they're ever having the symptoms of an infection, especially respiratory infection, it's going to be important to give antibiotics. Another thing that really has been shown to improve cough is cessation of smoking. Air humidification can be beneficial, although some patients do not find that to be very helpful. There's chest physiotherapy. There's cessation of protussive medications. So obviously, if they're on something like lisinopril and they have a dry cough, we'd want to get rid of that. And then there's also medications that we can give to help with cough. So we have opioids, which is one of the first line agents, but it is important to realize that if they are on scheduled opioids already and they do develop a cough, you probably will need to increase that dose of opioids to have a good enough effect to actually help with that cough. We also have NMDA receptor antagonists like dextromethorphan, corticosteroids, and then there are other therapies out there such as gabapentin that can be used for refractory cough that did not respond to opioids or dextromethorphan or corticosteroids. So there are a lot of options out there for cough, and it's going to be kind of start at one and go through. There's also things like benzonatate or Tessalon pearls, which can be used for central mediated cough. So it wouldn't necessarily be the best for this, since this cough is typically due to irritation of the lining in the lungs, but it still can be at least tried if everything else has failed, even though it is a centrally acting agent. Okay, and then another problem that we often see, which is another one of the common symptoms of COPD, is the upper airway secretions. So this can be very detrimental to their patients. And if you really think about it, it's going to be like, what happens is they lose the ability to swallow. They're still producing saliva. They're still having these secretions in the lungs, and they're not able to get rid of it. So a lot of times what we would use to treat that is anticholinergic medications. So we have quite a few. We have glycopyrrolate or Robenal. We have atropine, hyoscine, or Levsin, and then scopolamine or scopolamine, however you would like to say it, which typically is the patch. And they all have their own little niches. Typically, we use a lot of Levsin or atropine. Robenal is nice because it can be dosed twice daily, so it's more convenient for the patient and or nurse, depending on who's giving the medication. And then scopolamine, it's given every 3 days as a patch. The 1.5 milligrams is essentially it gets into the body over 3 days. There are some problems with it. It does make patients often kind of, I don't want to say crazy, but kind of, it can change their personalities or their CNS or their mental state. It's also very expensive nowadays, and in hospice, we have to care for what we're paying for and what we're costing to ensure that we're able to care for as many patients as we can. So other than that, that was my quick and dirty on COPD, and I would love if you guys had any questions for me.
Brad?
Yes.
It's Jim. Can you speak to the use of inhaled nebulized opioids or nebulized lidocaine for either dyspnea or cough?
So I don't have a whole lot of data on that. I mean, I know there's nebulized furosemide that does have some good data in treatment of COPD refractory to other treatments. As far as nebulized lidocaine, I've never actually seen that used, and especially not in my setting, nor have I seen nebulized opioids used as far as I've been there, although I've only been at my hospice for about 2 months now. So if you have any input, that would be awesome, and I would love to hear it. Chris?
Yeah, so this is it's one of those kind of questions that sort of rears its head about once a year. Everybody gets it in their mind that they want to use nebulized opioids for dyspnea because you're getting a localized effect, a systemic effect. The randomized controlled trials really don't show that it's any better than placebo, but it is important to know that there are, like all kinds of things in medical therapy, there are geographic predispositions by people to want to use it. So if you were in Richmond at the palliative care unit there, they like to use a lot of nebulized fentanyl because in their hands, from open label, non-randomized controlled trials, they see it to be very effective.
That doesn't seem very cost effective.
I think that, fentanyl is relatively cheap nowadays. And I think if you've got the right kind of control mechanisms, you can make it so that it's relatively cost neutral. The other group that seems to be very fond of nebulized opioids is the group at the Cleveland Clinic, where they've used nebulized hydromorphone. And again, in their hands, they think that in patients who get dose-limiting side effects with systemic opioids, they think that nebulized opioids do have a role. But the last review showed that, at least in a randomized controlled trial, it's no better than nebulized saline.
Okay. Well,
the only thing I would say about lidocaine is in patients that really are struggling with refractory cough, I've had a couple situations, again, this is anecdotal information, where using nebulized lidocaine did seem to help with intractable cough that wasn't responding to regularly scheduled opioids or other modalities.
Okay. Well, that's good to know. Thank you for that input. I do appreciate it. Very insightful for me.
So are James and Brad, are you two using oral opioids outside of the indication of pain for refractory or severe dyspnea?
Yes. I mean, a lot of times what happens, at least on our side, is that they'll have like PRN opioids on, and they'll start having dyspnea or something and call the nurse, and the nurse say, okay, we'll take this opioid because it will help with your dyspnea, or at least your perception of having dyspnea. They won't say it like that, but they'll say this will help you with your shortness of breath. So a lot of times I don't think it's necessarily like a scheduled thing for that, but if they are having dyspnea, and if it is continued, then we would do something scheduled to help with that. So yes, we're definitely using opioids in our setting outside of pain.
We actually tried to talk Dr. Middendorf into trying the nebulized furosemide a month or so before you started. And she was like, I'm not really sure about that.
Sounds about right. Great presentation. High frequency chest wall oscillation. So I didn't see the new vest that was approved. I know chest physiotherapy can be beneficial for COPD. I did not know there was a new vest that just got approved for COPD, though.
Interesting. I didn't know that either. Oscillation vests. Bet they're real comfortable.
It's like a chest massager, huh? Any other questions or comments for Dr. Rea? All right. Well, thank you everyone for tuning in. We'll be seeing you, I guess, next week, and I'll try to get the topics out. Brad, another great presentation, and thank you so much for continuing to educate us all on end-of-life care issues. So we'll see you guys all soon, and have a great weekend.